Good morning, everyone. I'm Monica Smith. I am one of the co-creators of Revel 11 along with Joni Parsons. And we started Revel 11, over 6 years ago now, with the goal of hosting events and experiences with meaningful conversation about topics that are important to us. And I am astounded at how many friends have suffered with debilitating migraines for years, but also maybe since the onset of menopause, and that's one of my questions this morning for Dr. Riggins. So I'm excited to be having this important conversation with two wonderful experts. I'm happy to introduce our host for this conversation, Lisa Kleiman. Lisa is family to Revel 11. She's not only Joni's cousin, but she was Revel 11's Pilates instructor since the beginning of the pandemic. And so she was our Pilates instructor for over 2 years. And she's a public speaking coach and consultant to executives and others. So I'm just thrilled to have the two of you join us this morning. So I am handing this over to you, Lisa.
All right, thank you, Monica. And welcome everyone. It is my utmost pleasure to be sharing this next hour with you about this very important topic. I wish we weren't having this discussion. I wish this didn't exist, but it certainly does. And that is regarding headache disorders and migraine. As you may be aware, and I assume that because you are attending this session that you are at least curious and maybe even you experience or know of someone who lives with and experiences migraine or some type of headache disorder. And if that's the case, it's very common. Over 40 million people in the United States alone experience and live with migraine and headache disorder. And it's a disabling, neurological, very painful disease. And it also affects a lot of women. Unfortunately, there's no cure for it. Fortunately, there's been a lot of breakthrough treatment, especially within the last decade and 5 years, and new things coming out all the time that help people with their treatment to reduce the severity and frequency of migraine. I am here today as an advocate for migraine. I myself fall into one of those statistics. I've experienced migraine. Actually, I was diagnosed in my early 20s with chronic migraine and also with cluster. Now, this was way back when. I've been experiencing this my whole adult life. And so that was way back, not to age myself, but when there was not a lot known about this disorder. And what happened to me was in my early 20s, I was at my desk on my computer, and I suddenly had visual disturbances where I couldn't really see. I had these flashing lights in my eyes, and I couldn't certainly focus on anything or read anything. And I suspected that it was migraine because I have a family history of migraine. And the only thing I could do was really just sit, close my eyes, and then just wait it out until those flashing lights went away. And I don't recall, maybe it took 15 or 30 minutes or so for that to happen. Following that, then I just didn't feel well. So that was my first episode of what was a migraine attack, and that included aura. And then it happened again, and the frequency got more and more migraines, and the effect of it became more severe. So I eventually went and saw a local neurologist who at the time, and even back then, there were not a lot of special healthcare providers that specialized in migraines, still not enough today. So we are very grateful for those who have focused their profession on this. And so really it was just someone who had some training in migraine disorders, and it was just trial and error. There was not a lot known. We didn't have all of the resources available as we do today, which is wonderful. But we just tried everything out there. And there wasn't any specific treatment for migraine. So we tried treatment for other things that had shown to help people with migraine. And that's what we did. For the most part, nothing really worked for me. So it was more just at that time, and I still apply today, more of lifestyle changes, learning what those triggers are. And so for me, it's pretty much check of everything that can trigger a migraine that is known, and it's fairly common amongst people with migraine. And that relates to types of food, such as artificial ingredients, artificial coloring, anything that's really too much of something, like too salty or too sweet. Alcohol is a huge trigger. Altitude, dehydration, stress, I mean, the list goes on and on. And so I then try to avoid those triggers. But the thing about this, and you may be able to relate to this, is migraine is not one size fits all, and you can't help it. Yes, you can try to prevent it from triggering, but still you can get it. And so for people who don't understand it, and even in their best interest, it can be frustrating for those who experience migraine, because you know it's not your fault. And people may tell you, or at least they've told me, hey, just take a few aspirin, drink some water, go to bed, and you'll be fine, right? Or, oh yeah, it's just a headache. You know, it's all in your head, right? And that's not normally the case. For me, migraine has affected my life in a way I wish it never would. I would never wish it on anyone. It's meant that it's prevented me from being able to show up for important things. I've had to not be able to, I've had to say no to things. I've had to sometimes not be able to commit to things because it's debilitating. And it's not just the pain, which, by the way, I've broken bones and I've had injuries, and nothing compares to the pain of migraine. I mean, it's so painful, but it also affects one physiologically. And so it can affect people's ability to think well cognitively, be able to speak clearly, be able to respond in a way that they want to, and really just to show up and be present. And for that, I've been misjudged. And I don't mean to come across in a certain way, but when you're not feeling well, when you have this war inside your head and it affects your ability to communicate, then I've come across as being rude or lackluster, not really caring. And that's not the case. Of course I do, but I'm trying to deal with my own internal issues, how I'm feeling, thinking, and so on. So I missed out on important events with family. It's affected what I've done with my profession. And for the most part, I've tried to just endure it and not disclose that I have this, because I don't want to be labeled as this person who experiences migraine. And I don't want it, I've never wanted it to affect my job. I've always wanted to be the person who I want to be, and to be people to think of me as not someone with a migraine, but to show up and to do the things that I want to do. And migraine has sometimes prevented me from doing that. So fast forward, this isn't all about me. You didn't show up to hear me, but to hear more about migraine. And so for that, I want to introduce our guest speaker for today. And it's with great honor that I introduce to you Dr. Nina Riggins. And let me just give you a little background about her impressive credentials here. So Dr. Nina Riggins is a neurologist, headache specialist, and the director of the Headache Center, Department of Neurosciences, University of California at San Diego. Her impressive credentials also include Vice Chair-elect of the Headache and Facial Pain Section and Vice Chair-elect Brain Pack Executive Committee, American Academy of Neurology. She's also the Vice Chair, First Contact Headache and Primary Care Committee, American Headache Society. She is especially passionate about working on challenging cases with UCSD neurology team to help patients return to a high-functioning and pain-free state. Her research investigates causes and treatments for headaches. Her studies of specific therapies include Botox injections, a new class of drugs known as calcitonin gene-related peptide receptor antagonists, and a procedure called, and Dr. Riggins, maybe you can help me with this, sphenopalatine ganglion block
Very impressive.
Oh, thanks. Okay, she's also studying the possible relationship between migraines and cochlear implants, devices used to restore a sense of sound to people with severe hearing loss. Very impressive background. And of course, she's an incredible person, so personable, and you can see her beautiful smile. She just resonates beauty throughout. So it's with such honor that we have her here today to share migraine, the causes, the treatments, how you can get started, what to do for when you see a headache specialist, and so on and so on. So Dr. Riggins, welcome.
Thank you so much, Lisa. That's amazing introduction. And thank you so much for sharing your story. I'm very honored to be here. And I was prepared for this wonderful conversation with Rebel 11, but I didn't realize that it's all women's organizations. So as you probably know, migraine affects more women, more prevalent in women than in men. So 1 in 5 women would have migraine. Even kids can have migraine, 1 in 11 kids. It's almost breaks my heart every time when my adult patients tell me that, oh, I thought everyone has headache every day of their life when I was a kid. And I work with people living with migraine and other headache disorders. And I'm advocating for our patients and our profession. And I actually have to say that I met Lisa during Headache on the Hill advocacy event. And even since that time, we've been members of the same team advocating for people living with migraine and other headache disorder. And it means a lot to me to be invited here. I'm very honored. Thank you.
Yeah, thank you so much. Well, I have a whole list of questions for you and for everyone out there attending. If you have questions, please feel free to share them. I ask that you post them in the comments section, and we will hold off addressing questions till the end because we have a lot of information that we want to cover, and hopefully we'll get through everyone's questions at that time. All right, so I'm going to start with the first question, and that is, what are migraine triggers? And really, what are the primary reasons why people suffer from migraines?
Thank you so much. So migraine is genetic neurologic disease. Because of that, actually a few years ago, we started to call it migraine instead of migraines. So person living with migraine always trying to tune in and sometimes avoid those triggers which can provoke and cause migraine attacks. And some of those triggers under our control at times, and some of those triggers out of our control. Example would be weather changes. And we know that triggers cumulative. So when one knows that some inevitable trigger going to happen, like some people have headache, exacerbation, so more of pain during airplane travel, and they have to travel, we would recommend to control other triggers such as go to sleep on time, hydrate. So 1 in 3 patients, people living with migraine, report that they would have migraine attack if they didn't drink enough water. We would recommend stay on good exercise plan. I actually learned only today that Lisa was Pilates instructor. So we love exercises. If one exercise about 3 days per week for 30-40 minutes, it's really shown in our research to be equitable to effects of our most powerful medications. So that's wonderful for people to exercise. and we do exercise together. We come, and Lisa, we were walking together within one of our walk. It's actually national organization now, Miles for Migraine, and whole idea that we exercise and getting better together. And sometimes it's yoga for migraine, and sometimes probably Pilates for migraine. So that would be examples how we can counteract some known triggers. But migraine is not someone's fault. It's genetic neurologic disease. We didn't learn yet how to block completely or take out action of this migraine gene. So what we're doing right now in medicine, we're learning more, we're doing more research. We learn 3-4 genes which we know for sure can cause certain types of migraine. But it's so complex that we have many more things to learn. And for now, we do treat it symptomatically. We try to avoid triggers when we can, but idea of treatment for migraine is for person to function, to live their life.
Okay. Yeah, no, thank you so much for that. And I can certainly contest to that. When I fly, it triggers a migraine for me. And so I'm conscious of the night before I'm going to fly out, make sure that I do what I can to avoid those triggers. And that includes what I eat, try to get to bed on time, hydrate, and all those kinds of things. And the cumulative effect as well. So like if I have alcohol, it's a typical trigger. If I have maybe a half a glass of wine, it may or may not trigger it. But if I have the next day and I have another glass, then certainly that could send me over the edge, that kind of thing. So it's kind of you just this little balancing act of, is it going to affect a migraine or not? And I was going to ask you if they're hereditary, but apparently it is. And I know with my family, I've had a family history of migraine as well.
Yes,
Yeah.
it's definitely runs in families. I sometimes, when family present, we ask this question with permission, of course, and sometimes our patients already know about it. Very interestingly, there is some familiar predisposition to some sort of auras too. So 30% of people have migraine with aura and 70% without aura. So it's a lot of research going on to see if visual changes or changes in speech or cognitive changes may be also run in family and effects of that.
That's so interesting. Yeah. Well, as I mentioned earlier, that there weren't a lot of treatment, there weren't treatments directly for migraine all those years ago. And now we have these breakthrough treatments. And I'm happy to share that those treatments have helped me reduce my severity and frequency of migraine. But can you describe what those recent treatments are, what's working that reduce and hopefully eliminate migraine?
Yeah, we working in all directions. So in the past, what we had medications which we kind of borrowed. Like example would be medications which work for person with migraine, but medication for blood pressure or heart rate decrease. Example could be propranolol. Medications which used to be anti-seizure medications, such as Depakote, which has a lot of unwanted side effects, especially during pregnancy. And we did not have specific targeted therapies for our patients living with migraine until very recent. And so first revolutionary discovery happened with triptans. In about 1980s and 1990s, this first triptan, I still hear some patients remember that, and they say that definitely was life-changing. It was maybe one of those things that helped me. And triptans little bit tricky, and a little bit tricky to use in a sense that person who has heart disease or had stroke or significant risk factors for vascular disease, they shouldn't use those medications because they narrow vessels. And we work very hard in research community, and now we have one of medications of new class. It works on serotonin receptors such as triptans do, but it doesn't narrow vessel. It's very first ditan called lasmiditan. And both of those may be implicated in medication. We don't like actually anymore saying that rebound or medication overuse headache, because it puts pressure on the person. And it brings me to wonderful new discovery, GPANs. So with GPANs, actually, we don't have to ask person to try to limit those to avoid rebound or medication overuse headache. We actually have GPANs which also they preventive. And so the longer person takes GPANs, the better person will get with migraine potentially, as opposed to saying, please don't try to judge when you should take medication. It's very tricky. When you are in pain, it's wonderful to have medications to stop the pain now and to not be in worry about day tomorrow that it will lead to some more medication-driven headaches. So that's been one of the major philosophical changes in migraine treatment, that now we have acute medication with preventive actions.
Okay, right. And can you share what some of those specific types of migraines are, the names of those medications are?
So one of medications which actually approved for acute and preventive treatment, it's called rimegepant.
Okay.
Another medication, I jokingly call it brothers or sisters of each other. So basically same class, it's ubrogepant, and you will see sometimes commercial on the from some stars going on about those medications on TV and on your computer. And then we have medication atogepant, which is preventive gepant, CGRP blocking medication. And I love when we have beautiful side effects which we can use for us. Example could be with all the classes of medication, when someone uses it for migraine treatment, but it controls blood pressure, with new class, atogepant, been published to actually help weight management. So not everyone needs it, but it's been published that with atogepant, it was pretty statistically significant reduction in weight, and could be used for people who looking for that, which is in few years ago, we only have the pyramid with these potential side effects. So,
Right. Yeah.
so it's getting into very good era when side effects getting better and treatments are targeted. I love for this reason to use devices. So we have 5 FDA cleared devices for management of migraine. And we actually have one more device which we use, and it's no script needed. It's green light. So 5 FDA cleared devices plus lamp plus maybe blue blocking glasses. Those I consider to be our friends, which we can use without fear of that if I have side effect, then it will not go away, or I cannot stop it right away. Basically, right now, if you didn't like device, you can put it back in the box and send it back.
What is green light? Is it just a light that emits green color?
It's developed in Harvard lab by Dr. Bernstein and his research lab. And we have it at UCSD Headache Center in every room to show, and it creates this very nice atmosphere. It's not disturbing for the eye, and it can even help anxiety and insomnia, according to most recent articles. So it's really new era in treatment, and it can go from high intensity of light to lower. It looks really nice in the way that if one now doesn't want to be in green atmosphere, if you turn it around, it actually creates just regular light, but without fluorescent frequency.
That's amazing. Yeah, over the decades that I've experienced migraine, and as I had mentioned before, I tried, almost everything out there. I was just so desperate to have treatment, but the side effects were, for many of them, just too much. And sometimes these side effects were worse than not the pain, but just were not intolerable. So it's so fantastic that we have so many different options now, and we're getting more options for treatment. But with that, what can one do to prepare, especially for their first time visit for seeing a migraine specialist? What should one do so that they are as prepared as possible to have the most effective visit when they see that specialist?
Yeah, I would definitely prepare a list of questions that you have. We love questions. We also definitely benefit if one knows which medications were tried, didn't work, or work well, if they had side effects, if allergic to some medication. So we don't offer something which didn't work before, and we build on what was potentially well tolerated and worked well in the past. Headache diary, according to research, it's really helpful to give so much information that in 97.7% of times we have all information we need during first appointment if one comes with headache diary. And for me, headache diary, in addition to be like little detective tool, what worked, what didn't work, it's giving control to person living with migraine. So we can figure out together, even if someone still reported level of headache the same, but medication for acute treatment went all the way down. It's little success, and we celebrate, but we keep going.
Mm-hmm. Okay. Yeah, that's so important. And I know personally, especially in chronic, when I had more days with migraine than not, fortunately, that's not the case now, thanks to the latest treatments out there. But when I had a day that I was pain-free, I really noticed it. It was such a great day. Like, oh my gosh, I feel good today. And so even sometimes those baby steps, just to have a day more than you would normally have. And then of course, trying these different things. So it's really important to know yourself and know what those triggers are. Take the time to track it even every day, so that when you do go talk to your headache, your healthcare provider, you only have so much time to do that. You want to make it as efficient as possible. It's about you. It's all about you. So, take care of yourself and do what you can to prepare. So with our audience here, the majority, if not all, and excuse me if I'm missing out or eliminating some of our guests today, our attendants today, but most of our participants, I believe, are women. So what are there any specifics regarding how migraine affects women in that classification?
Thank you. That's very important question. So migraine likes stability. And that comes with sleep on time, eat on time, exercise regularly. So it comes from this structure in this actually central brain hypothalamus. And everything which is not stable, even unstable level of stress, sometimes happy stress, someone has wedding and very happy, but even that can be triggering for person because it creates this unstable, unusual level of stress and hormones coming with that. So 33%, about 33% of women start to have migraine during first menstrual cycle. So that's very classic what we hear in the clinics from person living with migraine. And we understand that nowadays there's a lot of mechanism we can help. In the past, a study was published, and it really was astonishing for me how many people living with migraine decided against having family, having kids because they had migraine. And I have to say that during pregnancy, not 100%, but we're very happy to share that up to 80-90% of people improve because hormonal levels stabilizing. So baby can help, but we don't say anymore, and we ask everyone, please don't tell our patients to get pregnant because we support everything person decide. It's all about you. So if someone wants to start family, we will regroup our medications and we'll prepare for pregnancy together. If someone saying I don't want to build my family now, it's perfectly fine. And we have wonderful actually different means to stabilize hormones, and we work together with OBGYN in this way. And then during perimenopause, again, instability changes, migraine attacks can again go up, and we go through that together. And there is a lot exists what we can offer, from mini preventives to preventive everyday to all these new therapies. And that's just to basically reflect statistics that we do have about 1 in 5 women who experience migraine.
Yeah, well, and again, for myself, that was another huge trigger was during my menstrual periods. And for almost 7 days straight, I would have just yucky migraine attacks. Then when I was pregnant with my daughter, no migraines for the whole duration. And that was beautiful, so blissful. But again, that was my experience. It's not everyone's. And so it's hopeful to know that there are things out there that can help people through those experiences. Let's talk about insurance. I know this is a question that's come up. Navigating insurance. A lot of these treatments are very expensive. So what can one do to try to get it covered and not have to pay out of their own pocket? What are some tricks, strategies?
Yes. Mm-hmm. Those are different for different treatments. We actually went a few years ago with our patients to Chronicle and talk about FDA approved devices doesn't mean that insurance will cover or pay for those. VA hospital now covers most of devices, which is wonderful. But we still working and keep publishing research and keep talking with policymakers about covering devices approved by FDA for our patients. Mm-hmm. I remember times when we didn't have those, and person would go and sometimes even go to neurosurgery to implant those devices, and they had battery and leads. And now we have this wonderful option, and cost is a barrier. So this one, we just have to advocate together.
Mhm.
And we learn about different programs which exist. We share them with people living with migraine. And actually, sometimes people living with migraine share what they know with us, and we just spread the word about useful things, how to get devices to our patients, which we recommend. And about medications, we just have to do good job from our provider's point of view. We document, and starting with first appointment, we document list if someone tried medication before, and we keep together all this list. And if insurance says, oh, you have to try these 2 things or these 3 things first, we're ready to go with our list. So that's still tricky process. And headache on the hill and neurology on the hill, the top issues for neurology on the hill this year was fixed prior authorization. So we have wonderful medications. We didn't talk about those big molecules that block CGRP, and you can use those to block this substance of pain by self-injection, sometimes once a month or once a quarter. There is infusion exists once a quarter, and those are powerful treatments for migraine, and most of them require prior authorization. And many medical offices provided statistics that at least 2 days a week or more, everyone working on prior authorization only. So we have a lot of work to do. And this is a big part of our coming together, and us as doctors standing by our patients and basically asking for no barriers to care, know the steps to treatment which we believe best for this particular person. But at this time, we just have to create very good, from our point of view, we have to create very good note and put our thoughts in place. I can give example, I do it pretty often. Insurance very often require trial of blood pressure or heart rate decrease medication before we can start Botox or botulinum toxin A for chronic migraine. And if person has low blood pressure, I would document it. I would say, in my medical opinion, it's really no room to decrease this blood pressure or heart rate. We work together on that. So most of the times we can make it happen together.
Yeah, I would recommend people not try to navigate this on their own, but really work with their healthcare provider, and so that you can understand what is needed in order to get the insurance, get your treatment covered. And sometimes it does take effort. I know that with my current insurance, we switched insurance carriers a couple of years ago, and the previous one was easier, I should say, and this new one that I'm on was a lot more challenging, a lot more steps, a lot more back and forth, and it can certainly be frustrating. But it's my health. I'm the one experiencing it, so I'll do what I need to do. And this may be ongoing every year that I have to deal with this, but there are options, there are ways, and sometimes it's knowing even just the wording that's used. For example, you have to maybe prove that you do have chronic migraine, and in order to get the specific treatment covered. There are also options available directly with the pharmaceutical companies who manufacture and produce it, that they offer. Sometimes you can get them for almost free. For up to a year, maybe even more. And these include some of the latest treatments out there. So it's worth to ask the questions and do your research and find out, because you shouldn't have to pay a lot for treatment. All right. So with this, can we outgrow migraines?
Well, it's interesting question. The people who actually have migraine, which goes up with menstrual cycle or around menstrual cycle, more likely, as shown in literature, to kind of overgrow those exacerbations after menopause. So that can happen. But then we do see a group of people who actually can start having migraine attacks after menopause. So those changes, they can be tricky to pinpoint. In general, yes, it's possible, but it might not be true for everyone, and we just have to regroup. I do see some interesting trends in medicine from different times. One could be started on some estrogen or progesterone, on hormonal treatment years ago. And I always think about it that we change and body change. And so if you are on something from 30, 40, 50 years ago, that could be time to revisit. Maybe measure, maybe have discussion with your doctor, with your OBGYN, women's health, primary care. And I work very closely with them, and its collaboration is so appreciated because it's can be measured, it can be tuned up to make it better. Yeah, I work. Yeah, that was bringing me to this first contact headache in primary care. This is coming from headache specialist to everyone in primary care, OBGYN, and this part of organization, Headache Society, we actually include all of this specialty, and we work together, and we learning from each other. Like, it was astonishing for me to hear one of the doctors from different specialties said, oh, I actually didn't realize that only 30% of people with migraine have auras. And I was surprised that actually OBGYN doctors, they really appreciate that the system ABCD during pregnancy went away. And it was a reason. So we learn from each other and we publish it. It's not protected by any passwords. It's all free information for everyone.
Yeah, that's fantastic. And by the way, I don't want to forget to let people know that I posted a list of migraine and headache disorders resources with links there in the comment section there. And if you're not familiar with them, I highly recommend at least opening them up and digging through. They're full of information regarding all that we're talking about and more. Within those resources are other resources, including ways that you can get involved if you want to. So if you want to learn more about the migraine and headache disorders, these are really good resources. I highly recommend them. Now, what I feel fortunate because I live in San Diego, in a city where, like you, and there are a few others specialists, so grateful for that help people with their migraine. But what about those that don't live in an area where there are physicians and headache care specialists in their area? What can they do? What would you recommend for them as far as getting treatment for their headaches, migraines?
The first thing come to my mind, I wanted to say telemedicine. It's actually for headache and for migraine. It works so well. For some specialties, when we don't rely on our conversation and questions so much, it's more tricky. But taking history and discussing treatment plan for migraine, maybe as first appointment as start, would be very useful for someone with migraine. And it's actually saves driving time, and maybe you avoid these lights in the office and smells. So it could be really beneficial.
Wow, that's great. I didn't even think about that. Those are great points. Oh, thank goodness that we have this available to all of us. Well, we are already at the last 15 minutes, and I have so much that I would love to hear you talk about and questions and so on, but I want to give others a chance to ask questions. So I'm going to open it up, either post the comments on the side or go ahead and open up your video and then you can ask orally as well.
I can take one of the questions here, which is a website which has list of migraine specialists in US. There is couple of those. American Headache Society has it. And if you're looking for someone who UCNS certified, so headache specialist, it's a number of those fluctuates. It went from 600, 500, 700 in US, but it's not protected by any barriers. It's on UCNS website, and I'm proud to be working with them and being on the exam committee. So it's really dedicated group of people, and we're making sure that we have very good testing, making sure people know and spread knowledge around to our patients, which actually addresses why does it take years before patient gets clinically diagnosed. I hope we will change it. Join our advocacy. As me and Lisa, we definitely working on advocacy, on making sure that our patients get treatment they deserve, and persons living with migraine, and also working on stigma. So it's been really stigmatized in the past. And presentation, we discussed a little bit with Lisa's thoughts about how people with migraine want to be seen. And in my experience, majority of people saying that I want to function, I have family, I have life, I would like to travel, I want to have vacation. So people want to function and have their life, and we are here to support it. My goal as physician at this time, because it's genetic neurologic disease, we cannot say never again you will have migraine attack, not yet anyway, but we say we will work together so you can have vacation, you can do activities that you would like to do, and that's our goal, functioning.
Okay, very important, very helpful. More questions, feel free to ask them. I just reposted the list of resources, so hopefully you can see them. If not, maybe Monica, after following this, I can send it to you and you can send it out.
Yes, I would. I will send the list of resources to everyone's email. And if you joined this call through other resources other than Zoom, email me at monicasmith11, monicasmith11 at icloud.com, and I'll get those to you. But Dr. Riggins, can you answer the question in the chat about the histamine connection? I think a lot of people are curious about that.
Yes, and I'm going group histamine connection with other questions about potential conditions around migraine. So migraine associated with multiple conditions. So some of them as histamine or POTS or mast cell syndrome, or this connection of migraine and gut got dismissed for a long time. And we definitely learning that we use medication which is they use related to histamine very often, like all the medication called cyproheptadine, or all the medication with new use, which we're using for acute migraine management sometimes, hydroxyzine. Those are working on histamine. And mast cell syndrome, like related to all this more inflammatory area, we published and we research more and more. So definitely yes, gut-brain connection. Definitely yes for histamine connection. I saw in the chat polycystic ovarian syndrome. Absolutely yes. So all of those. I just was scanning for questions. It's almost like different very good build on this topic about migraine and comorbidities and how do we address that. People with migraine with aura more likely, for example, during pregnancy to have preeclampsia or eclampsia. Why is it? And so there is a lot of connections, and all your questions here, they just say, yes, we need more research and we need to show how to work on these connections better.
Mhm.
I have a question about getting involved. Are there clinical trials that our audience could potentially sign up for to help this research along?
Absolutely, absolutely. Our trial, I think my one of the favorite trials we're doing right now is actually with blue blocking glasses for people who have traumatic brain injury. And we know that blue blocking glasses can be very helpful for person living with migraine. So now we have these placebo glasses and we have glasses which block this blue light. And I love research which can really help people, but I also not very concerned about side effects with this one. And this is just one of example. It's this one very nice, very straightforward research, and we're looking at the numbers with statisticians, hopefully soon. But there's also more complex trials. We're learning how eyes move, effects of light. We're learning about all these different biomarkers. So goal would be when we talk and we have biomarkers, even when we talk first time, instead of saying, oh, let's try that and see how it works, it would be fantastic. And this is the future which I'm looking forward to say with this, that medication would work the best. Let's do that because of this biomarker. So go from more trying things to more scientific way. I think our mood doctors, they more close to that than we are in migraine, but it's not perfect yet.
Mhm. Yeah, that's fantastic. I'd like to add that for anyone experiencing migraine, don't feel like you have to go it alone. And that I know when you're going through an attack, and it can sometimes feel that way. And it's just no fun. But there are communities out there, and it might be helpful for you. There's just tons of communities of other people who are in this migraine headache disorder world. And so sometimes it's just helpful just to find out what other people are experiencing, even what they're using, and just to kind of educate yourself and feel a sense that you are not alone. Migraine does not discriminate. It can affect anyone. Even well-known people for over the eons have had migraine. So you have to be an advocate for yourself. Of course, if you can advocate for everyone else, that's great, but for the most part, the most important is to advocate for yourself. So the list of resources is one up, are some options that do have that different communities that you might be able to join that work for you. Just, of course, be aware with any kind of, especially with social media, people might sometimes post the extremes either way. So you want to take that with a grain of salt. All right. Any other questions? We just have a few minutes left.
I can see that we actually extremely good questions. I'm super excited about those questions. Like one that right in front of me, how to determine whether it's migraine or sinus. These fantastic questions. For years, before last 20 years, many people even went to sinus surgery because migraine sometimes comes with those symptoms. People can feel congested and sometimes nose running, and ears can feel full and congested. We call them cranial autonomic symptoms. So migraine is disorder of different brain networks, and part of nervous system can get activated. And one of the reasons is blocks work on those ganglions of this nervous system to calm them down. So we like using those. But for years, when we didn't raise awareness yet, our patients who potentially it was due to migraine, they would even do multiple sinus surgeries. And so distinguishing and working with your health professional will help not to miss sinusitis, because sinusitis is real and we diagnose it and we work closely with primary care and ENT doctors, but definitely watch out for unnecessary surgeries and work with your primary care and hopefully headache specialist, neurologist, on making sure that migraine wasn't missed and those symptoms is not attributed to migraine rather. So because it's very big part of migraine cranial autonomic symptoms for many people.
Okay, all right. We just have like just a few minutes left. Dr. Riggins, do you have any parting words that you would like to share regarding this whole important topic?
I always love to bring up lifestyle modifications. I think this is my favorite. They're so powerful and with basically no side effects. So there is very good article, if you can just type it, it's called Seeds for Success. And this Seeds for Success, basically a mnemonic for lifestyle modification, which includes sleep, diet. So many people, they when they say I'm going now start diet, I tense up a little bit, and then we launch into discussion. Healthy diet is good, balanced diet is good, hunger not good. So please don't starve yourself. Like a balanced diet, but have healthy snacks throughout the day. Come exercise with Lisa. Apparently, I want to join class. And with whole our organization, we always love to do events where we can walk together or even relax together. We have some events they call walk, run, or relax. So we went with Lisa and with all our other team members and had very nice walk along the ocean for advocacy. It was one of highlights of my year, really. So those are very nice events, and they're relaxing, and you spend time with people who understand you more, maybe, and you build community. And it's all about, for me, it's all about community. And that big reasons that I'm so grateful to be here, and so grateful you are here, spending your day with us, because it is building community. Maybe now when we even virtually met each other, you reach out and you help other people.
Yeah, absolutely. Well, Dr. Riggins, thank you for that and your valuable time. I know you have a very busy schedule, and so we really appreciate your very helpful information. And with this, I really wish everyone all the best and hope that you can, just take it one day at a time. Do what you can to take care of yourself and get better, or pass on any information that you think can help others. So I want to thank everyone for their time. And Monica, I'll return this back to you if you have any last words that you would like to share.
Well, my last words are thank you so much, Lisa and Dr. Riggins. That was so informative. I really appreciate your time and expertise. And for the audience, thank you for joining us. Again, if you have any questions, please email. We will be following up.